Hi everyone, and welcome to your online lecture, Week 6, Toxicological Emergencies. This week's lecture is completely online. We will talk about toxicology and the various emergencies associated with it. There will be online case studies posted to go through as a part of your lab prep, and we will discuss this further next week to wrap up the concept. In class next week, you will have your presentation, so please come prepared to present. Remember, Google Docs Online serves as a really useful reminder for your topic choice and sign-up time. Please come for all of your classmates' presentations, as they are useful midterm reviews. Before starting today's lecture, I would like you to pause this video and take an opportunity to watch this YouTube video. It will give a general overview of toxicological emergencies. So, toxic agents are manufactured or naturally occurring chemicals that have significant effects on humans. Quantity required to produce effects very much varies widely among substances. Toxins can enter the body through ingestion, inhalation, injection, mucosal absorption, ocular exposure, or dermal contact. Management of the patient involves respiratory and hemodynamic monitoring and support, careful evaluation of toxicosis potential, interventions to reduce toxin absorption and promote excretion, and substance-specific therapy, which may include the use of antidotes, which we will review in today's lecture. In this lecture, we will discuss an overview of the assessment and management of the patient and go into specifics about a few common poisonings we may see as nurses. I have included some opioid overdose statistics, which include fentanyl, on this website, and also there's a global news video here, which I think would be useful for you to watch. So determining the exact agent or agents involved in a toxicological emergency can be challenging due to the large number of potentially toxic substances. Poison control centers are an excellent resource for information on various drugs, potential toxicity, patient assessment, and management. I have included the poison control website here. They are staffed 24/7 with nurses or pharmacists, and they provide evidence-based recommendation to nurses. Symptoms can range from minor to severe and depend very much on the agent, dose, and extent of exposure. Every body system may be affected, and therefore assessing the patient carefully and obtaining a detailed history is really important. Consider the possibility of a toxic exposure in any patient presenting with decreased level of consciousness without a known cause. Essential assessment information for toxic exposure. So we need to know what the substance was. That's ideal. Can we get the product's name? We want to know the route, the dose, the time of ingestion, the type of exposure it was. Is this acute or chronic? Have they received any prior treatment prior to coming to hospital? So has EMS or fire administered anything? Have they self-administered? Any signs and symptoms associated with the exposure? And was this intentional or was this accidental? It's also important to know the patient's weight or an estimate weight, obtain a baseline set of vital signs, get a baseline GCS. We want to know, were the meds taken their own meds or were they someone else's? Was there any other ingestion with this toxic exposure? Alcohol use, perhaps. It's also important to include a medical history, past psychiatric history, recreational drug use, treatment prior to arrival to the emergency room, and again, whether this was intentional or not. Table 42.1 in your textbook talks about the essential assessment information for toxic exposure. In regards to substance, if possible, visually confirm the substance involved and ask what medications the patient takes at home. We want to know the time since exposure, as this influences both symptoms and treatment. Acute exposures have different presenting symptoms and are managed differently than chronic exposures. Determining the maximum quantity possible of the amount of toxin that was ingested. We want to count the pills in the pill bottle, confirm when the prescription was filled. Assess for symptoms of all systems. Toxins can affect every tissue in the body. Clarify any interventions provided by lay and pre-hospital personnel. Some home remedies can potentially be detrimental. Poisoning is a popular form of suicide and suicidal gesture. Have there been previous suicidal attempts? Does the patient have a history of depression or pre-existing mental health problems? And was the poisoning recreational? Is this a possible homicidal attempt? That's also a consideration. We should suspect poisoning in any patient who presents with an altered level of consciousness of unknown cause. Suspect poisoning with patients that present with dysrhythmias, unexplained MVCs, dysthymia, metabolic acidosis, seizures, altered body temperatures, fire, and mental health disorders. General interventions always focus on our ABCs as a priority. Then comes patient and staff safety. Providing emotional support to both the patient and the family is essential. Knowledge of common toxidromes and interventions associated with each will assist the nurse in management of the patient suffering from a toxicological emergency. Emergency interventions to consider, again, always include our ABCs and our Ds, so airway, breathing, circulation, and disability / neurological exam. We want to complete a complete history and physical examination or head to toe. Place the patient on a cardiac monitor. Complete an ECG. Look at the labs and diagnostics that may be required for this patient. Toxin determination. Can we figure out what has been taken? Narcan, if needed, if this is an opiate overdose. We need to think safety. Does the patient need to be restrained? Other emergency interventions to consider may include activated charcoal, which we will discuss further, nasogastric tube insertion as needed, Foley catheter as needed. It's really important to get a urine specimen, and IVs. Limiting absorption. So decontamination is a mechanism to limit or decrease absorption of the poison or toxic agent. Decontamination can be divided into GI decontamination for ingestions and external decontamination for dermal or ocular injuries from a toxic agent. Specific interventions are really determined by the patient's condition and precisely the toxin that was involved. We'll start by talking about GI decontamination. So this refers to specific efforts used to inhibit absorption of drugs and poisons in the GI tract. There are 5 methods of GI decontamination, and they include induced emesis, gastric lavage, activated charcoal, whole bowel irrigation, and binding agents. Induced emesis. Emesis may be induced with a syrup. It's prepared from a plant, which contains the alkaloids emetine and cephaline. These emetics induce vomiting via gastric irritation and stimulation of the vomiting center in the brainstem. The use of syrup in the management of poisoned patients has declined. Several studies have found that the use of syrup has been associated with aspiration pneumonia, dehydration, a longer length of stay in the emergency room, and more complications. In addition, no real studies demonstrate that the use of this syrup in the treatment of acute poisoning changes or improves clinical outcomes. The benefit of using gastric lavage is to decrease absorption. Generally, gastric lavage is considered only when a patient has ingested a potentially life-threatening amount of poison, and the procedure can be initiated within 60 minutes of exposure. Before initiating lavage, the patient has to be in the left lateral position to decrease the risk for aspiration. Lavage should not be performed on people who have ingested medications that may cause abrupt CNS deterioration, such as tricyclic antidepressants, unless the patient has been intubated. It's not really recommended for patients who've ingested a corrosive agent due to the increased risk of esophageal perforation. For adult patients with pill ingestion, we would insert a large diameter orogastric tube with a bite block to prevent tube occlusion. With mechanical suction or a catheter tip syringe, you want to withdraw as much of the gastric contents as possible. Activated charcoal. This is the preferred method of GI decontamination for the management of most toxic ingestions. Charcoal is activated by exposure to high temperatures that dramatically increase its surface area. So this agent has an extensive network of interconnecting pores that are capable of binding and trapping chemicals within minutes of contact, therefore preventing their absorption and toxicity. Binding prevents absorption into the bloodstream, which allows toxins to be eliminated in the feces. Studies have suggested that its use alone, activated charcoal administration, is as effective or even more effective than administration of activated charcoal after emesis or after gastric lavage procedures. Activated charcoal should be administered as soon as possible after the ingestion. Some clinical experts report it is most effective if it can be administered within about 60 minutes of ingestion. However, there is really limited evidence to determine at what time frame activated charcoal is no longer beneficial. It may be effective for some agents beyond the 60-minute window, particularly for sustained release preparations or anticholinergic medications as well. Activated charcoal readily absorbs most poisons except heavy metals and alcohols. It is not recommended in patients who have ingested acidic or alkaline corrosives or who require endoscopy because charcoal can obstruct the view during the procedure. Substances poorly absorbed by charcoal include acids, alkali, cyanide, ethanol, fluoride, lead, mercury, and many more. Contraindications to charcoal administration include bowel obstruction or bowel perforation. Adverse effects of administering it include nausea, vomiting, GI obstruction, and pulmonary aspiration. Activated charcoal is generally given orally, or it can be given through a gastric tube in doses of 25 to 100 grams, or if it's a child, it's usually about 1 gram per kilo. It's prepared as an aqueous solution with or without sorbitol, and sorbitol helps the toxins that are bound to the activated charcoal pass through the GI tract. Following the recommendations of regional poison control centers is probably the key here. So if you can dedicate someone to calling poison control to get a treatment plan figured out based on what has been ingested is probably the best method. Binding agents we'll move on to. So binding agents limit the bioavailability of certain poisons. Magnesium hydroxide has been found to be effective in reducing serum iron levels. Sodium polystyrene sulfonate is often used to treat hyperkalemia and has been effective in limiting serum lithium levels as well. Other specific binding agents may not be as clinically applicable due to the limited availability. Whole bowel irrigation is a method of GI decontamination that entails administering polyethylene glycol orally or through a gastric tube until the resulting rectal effluent is clear. Polyethylene is not absorbed and is less likely to produce a fluid or electrolyte imbalance, so really that has to be considered. Whole bowel irrigation is used to treat large ingestions of drugs not absorbed by activated charcoal. An example of this would be like lithium or iron. This next slide just shows you a picture of what the activated charcoal looks like and exactly what it is doing in the stomach. So external decontamination. So external decontamination is the removal of a toxic substance from the skin or eyes, which will reduce the risk for absorption. So dermal decontamination involves removing the clothing, rinsing the skin for 10 to 15 minutes with water or saline. If the patient has been contaminated with a dry substance or powder, it should really be brushed from the body before washing it. And it may be considered a hazardous waste, so you have to consult your hospital as to how you need to get rid of those items. Ocular decontamination involves vigorous eye irrigation and something called a Morgan's lens, which you will see in the next slide in the picture. So this is a Morgan's lens. It pretty much looks like a contact lens, as you can see right here. It gets inserted into the eye. The patient can insert it or the nurse can insert it. It has IV tubing that is then hooked up to normal saline and flushes the eye. So, enhancing elimination. So after initial efforts to limit absorption, enhancing elimination of absorbed toxins is really the next priority in managing the poisoned patient. Techniques to enhance toxin elimination include repeating the dose of activated charcoal, fluid diuresis, hemodialysis, charcoal hemoperfusion, and continuous hemofiltration as well. When we talk about hemodialysis, hemoperfusion, and hemofiltration, they not only remove toxins and their metabolites, from the circulation, but also rapidly and effectively correct acid, base, and electrolyte disturbances. Substances such as Tylenol, alcohol, lithium, phenobarbital, they can all be removed with dialysis. Because of requirements for vascular access, dialysis equipment, and skilled personnel, hemodialysis is generally reserved for poisonings associated with really severe acidosis. Hemoperfusion is similar to hemodialysis, but it binds toxins as blood moves across a charcoal or a resin filter rather than the traditional hemodialysis filter and dialysate. Hemoperfusion achieves greater clearance rates from hemodialysis and is particularly effective for severe cases of poisoning. Continuous arteriovenous and venovenous hemofiltration have been suggested as alternatives to conventional hemodialysis when the need for rapid drug removal is less urgent. The role of these modalities in the management of the acutely poisoned patient remains somewhat uncertain. Substance-specific interventions. So in addition to minimizing absorption and enhancing secretion, key interventions include antidote administration and urinary alkalinization. So antidote administration. There are various antidotes available for specific drugs and poison. If the substance is unknown, you really need to determine the signs and symptoms and match it with a potential antidote. And again, poison control can be really useful in assisting us with this. Table 42-2 in your textbook lists the antidotes and their indications. Some of the examples would include administering glucagon for a beta blocker overdose, administering vitamin K for a warfarin overdose, giving high flow, high con oxygen for carbon monoxide poisoning, or giving naloxone or Narcan for opiates. Urinary alkalinization can increase renal elimination of salicylates and phenobarbital by changing them to a less absorbable ionized form. Continuous infusion of sodium bicarb can achieve this. The next slide is just a picture of a guide to drug overdose, including the initial assessment, whether the patient is symptomatic and asymptomatic, and exactly what we're going to do about that. So moving on to specific toxicological emergencies. So a patient may present with toxicity from multiple agents or a single agent. We should never assume the patient with a toxicological emergency only ingested one thing or one type of pill. We should always assume more. So in this next section, we will talk about some of the most common emergencies you may come across as a nurse. Salicylates. So these have analgesic, anti-inflammatory, and antipyretic properties. Aspirin is the most readily available and it's over the counter. Pepto-Bismol has bismuth subsalicylate in it. The incidence of this type of overdose is declining because of the increased use of Tylenol and Advil overall. Clinical findings related to salicylates. So symptoms of mild toxicity would include nausea, vomiting, dizziness, and tinnitus. Moderate toxicity occurs with an ingested dose of greater than 250 milligrams per kilo, and symptoms of a moderate toxicity would include tachypnea, hyperpyrexia, sweating, dehydration, agitation, and ataxia. Severe toxicity is associated with an ingested dose of more than 500 milligrams per kilo. Patients with severe toxicity greater than 700 milligrams per deciliter may exhibit hypotension, metabolic acidosis, renal failure, coma, and seizures. Acidosis can also lead to cardiac dysrhythmias and cardiac failure. Chronic toxicity may occur with ingestion of more than 100 milligrams per kilo per day for 2 or more days. Symptoms may include lethargy, confusion, dehydration, hallucinations, pulmonary edema, elevated liver enzymes, a prolonged PT time. Direct GI irritation causes nausea, vomiting. Sometimes there's blood in the emesis. Patients may also exhibit hyperthermia, renal failure, tinnitus, and hypoglycemia. Salicylates stimulate the respiratory center of the brainstem, resulting in hyperventilation and respiratory alkalosis. Diagnostic studies include serial measurements of salicylate levels, arterial blood gases, electrolytes, particularly looking at the potassium level, a glucose or blood sugar, blood urea nitrogen, creatinine, platelets, PT, and urine pH. You should obtain a serum salicylate level initially, or at least within 4 hours after ingestion, and then about every 4 hours until the concentration has peaked. Levels may not peak for about 12 to 18 hours after ingestion of enteric-coated tablets. Initial treatment consists of administering activated charcoal. Repeating that dose of activated charcoal should be considered every 2 hours until serum levels start decreasing. Gastric lavage may be considered if the patient presents within 1 hour of ingestion of greater than 500 milligrams per kilo. Urinary alkalinization is an effective method of increasing renal excretion in patients who exhibit moderate toxicity. And this is accomplished by adding 100 milliequivalents of sodium bicarb to each liter of IV fluid and infusing it at about 200 to 300 mils per hour. Potassium can be added to the IV to avoid potassium loss associated with alkaline diuresis. Sometimes hemodialysis is required. Sometimes the patient presenting with severe metabolic acidosis may need an additional amount of sodium bicarb IV. And if the patient starts having seizures, they may also require benzodiazepines as treatment. Moving on to acetaminophen or Tylenol. This patient may present very vague, nonspecific. Tylenol is absorbed rapidly by the GI system. It's metabolized by the liver into a toxic intermediary metabolite. Alcohol consumption along with Tylenol overdose really increases the risk of toxicity. And the most accurate serum level is 4 hours after ingestion of the Tylenol. There are 4 stages when we look at Tylenol overdoses. So the clinical course of Tylenol toxicity really occurs in these 4 phases. So in stage 1, the patient may have nausea and vomiting, abdominal pain. This lasts about 0 to 1 days. In stage 2, liver injury develops. They get some right upper quadrant pain, a rise in their liver function tests. This usually happens days 1 to 3. The patient may or may not be symptomatic during this phase. In stage 3, liver toxicity peaks. They get rapid and severe hepatic failure, encephalopathy, and hypoglycemia. They get glucose, lactate, and phosphate abnormalities. And most often in stage 3, which is around 3 to 5 days, they're at the highest risk of dying. Stage 4, if the patient survives, can last for weeks and weeks and weeks. This is the recovery stage. It's for those who survive stage 3. So the Rumack-Matthew nomogram for Tylenol toxicity. This nomogram is useful and will determine if the patient is at risk for liver toxicity. So in order to use this nomogram, you really have to have a known ingestion time. You would then plot the patient's serum level of acetaminophen on the chart. If a patient's 4-hour level remains below the line, so that's below this line here at 4 hours, there's no further treatment needed and no further testing required. If it is at or above this line, further treatment and testing is required. So Mucomyst is the antidote for Tylenol overdose. It can be given by mouth or IV. The initial dose is 140 milligrams per kilo. Charcoal is great. We can definitely use that, but it's really only great if given within 2 hours of ingestion. So again, you really have to know that ingestion time. We have ondansetron, also known as Zofran, and it can be a great medication to treat nausea and vomiting. So we're going to move on to NSAIDs. NSAIDs, ibuprofen or Advil, very common NSAID. If the patient ingests greater than 100 milligrams per kilo, it's usually associated with a lot of GI symptoms such as abdominal pain, nausea, vomiting, and diarrhea. Very large amounts of NSAIDs can cause drowsiness, coma, apnea, bradycardia, and renal failure. Basically, if the patient presents within 2 hours of ingestion, you would give them activated charcoal. You would always follow Poison Control's recommendations. Depending on their GI symptoms that may be involved, a proton pump inhibitor may be useful. CNS stimulants. So this is a group of legal and illegal drugs. It can include cocaine, meth, crack, speed, meds that treat narcolepsy, obesity, and so on. Others can include caffeine, pseudoephedrine. It can be ingested, injected, inhaled, snorted. It's absorbed vaginally, anally. Although CNS stimulants are not all the same, their actions, side effects, and hazards can be similar, but really vary depending on the degree of intoxication. It can be mild, moderate, severe, or late. Remember that street drugs, are often cut with other substances as well, so that really has to be a consideration. The overall toxic dose for a patient is variable. It very much depends on the patient. ABCs is really important for treatment considerations and interventions. Fluids for dehydration. An ECG cardiac monitoring, really important because of the risk of dysrhythmias, and benzodiazepines if the patient has a seizure. Opiates. So before we go into opiates, I'd like you to take some time to pause this video and watch the video located in this PowerPoint on opiates. The most commonly abused opiates that we see are heroin, morphine, codeine, fentanyl, Demerol, oxycodone, hydromorphone, and oxymorphone. Opiates are originally derived from the opium poppy. Opiates are among the oldest known analgesic agents, having been used for thousands of years. Today, opium is refined into many different drugs. Numerous synthetic opioids are also available in the US and in Canada. Single agent and multi-drug formula opiates can be legally obtained by prescription. Narcotic toxicosis is often associated with IV abuse of opiates. Overdose results from both pharmacologically prepared and street drug version of opiates. Illicitly obtained opiates may be cut with caffeine, amphetamines, PCP, lactose, or powdered sugar. Although there are significant differences among opiate agents, all act on the central nervous system, producing variable degrees of sedation, euphoria, analgesia, and amnesia. Their psychic effects make opiates popular drugs of abuse. CNS depression sufficient to induce coma can occur with large drug doses or with relatively small amounts in novice users. Tolerance and dependence are common. Addiction can follow chronic use. And there are potential effects of narcotic abuse and toxicity that can really affect a person's entire life. Moving on to benzodiazepines. These are commonly prescribed for anxiety and as a sedative. This class contains a large number of substances that vary widely in their indications, potency, and duration of effect. In overdose situation, benzos with other CNS depressants like ethanol or alcohol, opiates, etc., produce a more severe poisoning. Lab levels are not that useful because it changes really depending on the person. The clinical features of benzodiazepine intoxication include slurred speech, incoordination, unsteady gait, drowsiness, lethargy, hypothermia, confusion, and coma. Profound coma suggests involvement of other CNS depressants as well. Gastric emptying is of no additional value if activated charcoal can be given promptly to these patients. Hemodialysis and charcoal hemoperfusion have little benefit in benzodiazepine overdose. A medication called flumazenil is the antidote for benzodiazepines. It competes directly with benzodiazepines at the actual receptor sites. However, flumazenil administration can induce seizures in those with benzodiazepine addiction and in those with a concurrent TCA overdose. So because benzodiazepine toxicosis is associated with a low morbidity and mortality rate, the decision to administer the antidote must be considered very carefully. Moving on now to tricyclic antidepressants, or TCA overdose. These include our medications such as Elavil, Doxepin, Tofranil. The use of TCAs overall has decreased during the last decade because there's an increased use of SSRIs for the management of depression. Along with depression, TCAs are used for patients with chronic pain, panic disorder, OCD, And these overdoses are usually associated with some sort of suicidal intent as well. TCAs inhibit the cardiac fast sodium channels and adrenergic receptors and histamine receptors. They are well absorbed from the GI tract and are difficult to remove from the body once they are absorbed. Toxicity may not be closely associated with a milligram per kilo ingested dose. Generally, an ingestion of greater than 10 milligrams per kilo is likely to produce significant toxicity. Serum levels really don't correlate well with clinical effects. A qualitative urine study is pretty good just to confirm the ingestion of the actual medication. Because TCAs produce neurotoxicity, cardiotoxicity, and anticholinergic effects, signs and symptoms of poisoning really fall into three categories. So neurotoxicity is characterized by lethargy, confusion, delirium, and hallucinations. CNS depression, coma, and seizures can occur. Profound CNS depression can lead to apnea and respiratory failure. Cardiac manifestations include low blood pressure and numerous ECG changes, such as a prolonged PR interval, prolonged QRS interval, prolonged QT interval, ST and T wave abnormalities, conduction blocks, and tachycardia. A patient who has a TCA overdose, we will often see a sinus tachycardia present. Ventricular tachycardia and ventricular fibrillation are more frequent in very severe poisonings that are complicated by acidosis. The patient usually presents with an altered level of awareness, or LOC, hemodynamic instability. If you do that urine test, they will likely have a positive urine for TCA. They can have flushed skin, dry mucous membranes, anxiety, psychosis, tachycardias, temperature alterations, and urinary retention. Like I had previously mentioned, they can have progressive widening of their QRS. A major cause of death from TCA poisoning is refractory hypotension due to decreased contractility and peripheral vasodilation. Respiratory arrest can occur quickly, and death from TCA toxicity happens within a few hours of admission. We do not want to attempt to induce vomiting in these patients because CNS depression can happen so quickly. Continuous cardiac monitoring is imperative for all significant TCA ingestions. We can give sodium bicarb for acidosis. Hypotension is initially managed with normal saline boluses. Sometimes the patient may even need vasopressors. You can see in this next slide that patient can also have widening of QRS. So important to note with this type of overdose. PEA. Please recall, if you think about your advanced cardiac life support, that TCA overdose is one of the causes we consider when we encounter a patient with pulseless electrical activity. So this is a patient who is on the monitor, they appear to have a rhythm, but this rhythm is not generating a pulse. This is called pulseless electrical activity. Pulseless electrical activity has causes. The 6 H's and the 6 T's need to be considered. And in this case, TCA is known as a toxin and should be considered in this type of patient presentation. So overall treatment. Symptomatic, and supportive, your ABCDs, diagnostic tests, cardiac monitoring, ACLS interventions. Activated charcoal is really effective as it can increase the elimination of the drug. Give sodium bicarb, give benzos as needed, hemodynamic support, repeating doses of activated charcoal if needed. Moving on to toxic alcohols. So in addition to ethanol, 3 other alcohols can cause severe poisoning. Toxic alcohols exist in many common household products, not generally considered dangerous. Methanol, also known as wood alcohol, is found in windshield wiper fluid. Canned fluid, sterno, and solvents such as paint removers. Isopropanol is a major component of rubbing alcohol, disinfectants, cleansers, and nail polish removers. Ethylene glycol is an odorless substance contained in antifreeze, detergents, paints, polishes, and coolants. Its sweet taste and fluorescent color are particularly appealing to children and to pets. Toxic alcohol ingestions can be accidental, recreational, suicidal, or may occur in desperate alcoholics who are unable to obtain ethanol. In addition to oral ingestion, toxic alcohols may be inhaled or topically absorbed. These alcohols are relatively non-poisonous before hepatic conversion by the enzyme alcohol dehydrogenase to their toxic metabolites. The toxins, ethylene glycol, formaldehyde, and formic acid or methanol, and acetone produce widespread damage and metabolic dysfunction. Appropriate lab studies need to be performed to detect the following predicted abnormalities. In methanol intoxication, pronounced metabolic acidosis results from the accumulation of formic acid. Isopropanol poisoning causes elevated serum acetone levels with ketones present in the blood and the urine, and hyperglycemia can also occur. With significant ethylene glycol toxicity, both the anion gap metabolic acidosis and a large osmolar gap are evident. Sometimes some of the tests need to be sent out as well, depending on how large your facility is. Clinical findings often demonstrate CNS and respiratory depression. And some of the other clinical findings can vary depending on the type of toxicity, so whether it be methanol, isopropanol, or ethylene glycol. So treatment. Gastric lavage may be used. Intubation, ventilation, remember ABCs always come first. Ethanol in each of the toxic alcohols, like I had previously mentioned, rely on the enzyme alcohol dehydrogenase for metabolism. However, the liver preferentially metabolizes ethanol, alcohol. So therefore, the administration of IV ethanol saturates available alcohol dehydrogenase molecules and slows methanol and ethylene glycol degradation, preventing the accumulation of toxic metabolites or metabolites. It can also be used during dialysis. So generally, these patients are essentially given alcohol as a treatment. The antidote is fomepizole, and other treatable causes for altered LOC really need to be considered. Moving on to calcium channel blockers and beta blockers. Calcium channel blockers are used for the management of angina, hypertension, dysrhythmias, and in some cases as migraine prophylaxis. Some of the common calcium channel blocker agents include verapamil, diltiazem. Calcium channel blockers are rapidly emerging as one of the most lethal prescription drug ingestions. Children can become symptomatic with as little as 1 tablet. Overdose on short-acting agents is characterized by rapid progression to cardiac arrest, and overdose from extended-release agents results in delayed onset of dysrhythmias, shock, cardiac collapse, and bowel ischemia. Calcium channel blockers result in peripheral vasodilation, decreased heart rate, decreased contractility, and decreased conduction. Significant bradycardia, hypotension, and heart blocks are classic symptoms of calcium channel blocker poisoning. High blood sugar can occur because calcium channel blockade inhibits insulin release. Serum drug levels may be obtained, but often take hours to perform. Treatment really has to be considered based on symptoms and a history. An ECG needs to be obtained and continuous cardiac monitoring implemented. Cardiac markers may help to differentiate drug-induced bradycardia from ischemic causes. Atropine may be tried if the patient has hemodynamically unstable bradycardic. However, atropine is not always effective in calcium channel blocker toxicity. The patient may need pacing, transcutaneous pacing, if the patient is hemodynamically unstable and in a heart block. The patient may also require dopamine to improve their heart rate and heart contractility. They may need a bolus of normal saline if there is low blood pressure. Administer 5 to 15 milligrams of glucagon IV if hypotension persists. Glucagon is the accepted antidote for beta blockers. Either calcium chloride or calcium gluconate may be administered for hypotension or heart blocks that are associated with acute or chronic calcium channel blocker toxicity. Calcium is essential for contractility. Calcium channel blockers stop the movement of calcium, resulting in diminished perfusion. If performed within 1 to 2 hours of ingestion, gastric lavage might be helpful for extended release formulas. Activated charcoal is recommended for calcium channel blocker poisoning. DIG. DIG is available in pharmaceutical preparations such as digoxin. It can also be found in homes and yards. At therapeutic and toxic doses, digitalis glycosides block the sodium-potassium adenosine triphosphatase pump. With high serum concentrations, both vagal and sympathetic tone increase. Clinical symptoms can be very vague and difficult to diagnose. You might see ECG changes. If the potassium levels go up, you can see hypotension. And sorry, I should have separated those two. You can see hypotension and you can see high potassium levels. Diagnosis is really based on the symptoms that the patient has and serum DIG levels. We treat it with activated charcoal. The antidote for digoxin toxicity is Digibind, and it's usually only given if there are 2 or more of the following. So a potassium greater than 5, any life-threatening dysrhythmias, and a serum level greater than 10. And I'm sorry, in a lot of these PowerPoint slides I didn't notice before, but dysrhythmias keeps being auto-corrected to dysthymia. So anytime you see dysthymia, it should say dysrhythmia. My apologies on that. Organophosphates, heavy metals, iron, hydrocarbons, and toxic plants. These are all included in your textbook. You can read about these online. We will not review these in this lecture, and they will not be tested in this course. So in summary, toxicological poisoning is a routine cause of many visits that we see. Nursing diagnoses can be found in your textbook. Initial focus on these types of poisonings always starts with our ABCs as a priority. Treatment priorities include limiting poison absorption, enhancing elimination, and providing antidotes and supportive interventions for that patient. So that's it for today. I know it was a bit of a longer lecture, 50 minutes, but I think we got through everything we needed to cover. Please jot down some questions that you might have about this week's lecture that we can talk about as a group. And otherwise, you are free to move on to the lab component of today's lesson. I will see you all next week. Happy studying. We will have a midterm review. And we also have our presentation, so I hope you are all working on those. Have a great night.